officially came out as a dissociative system in 2018, the article we wrote was called Combating Dissociation Phobia in the Clinical Professions. Because phobia or fear is something that we see drive a lot of clinicians, even solid clinicians who have good trauma therapy training, yet still fundamentally seem to be operating from myths and misinformation about the dissociative mind. Or a lot of clinicians tend to catch this contagion of fear from trainers or people they've studied with who say things like, don't let a client dissociate, or if a client's dissociating, they're not going to be able to really do deep work. Hopefully, we've made a case in this course so far for why that's not necessarily the case. And in this lesson, we'd like to go further into some of the myths, misconceptions, and quite frankly, horror stories that we've encountered around the way that clinicians and clinical trainers can handle dissociative identity disorder specifically, and really all dissociative disorders. So as I go through these points, I would encourage you to do a bit of self-evaluation. If these are things you believe or things you've heard, please hear us genuinely. We don't see you as a bad person. We see you as somebody who's just been around this field for a long time, where these myths and misinformations can abound. And ours went as far back as our own graduate training. When we were in school, this was 2003, 2004, we had a professor in the 2 minutes, that's hyperbole, maybe it was 10, the 10 minutes of time we got on having dissociative disorders covered. And something that this graduate professor said is DID is so rare, you're barely going to see it. We're not going to waste time on it here. There have been something like only 200 cases of true DID that have ever shown up in the world. We have no idea where they got that number. And as we got into our own healing and recovery, we learned just how off base a lot of that education was. And what's sad is that we still hear this going on in some graduate programs today. It's a little better than what I encountered back in 2003. Yet, because this misinformation, because this bias can still abound, we do feel it's important to unpack these, and this may invite you to challenge some of what you have learned. So, one of the definite myths that is out there is that people with clinically significant dissociation, especially those with DID, do not respond to treatment. It can get this label as one of the hopeless disorders for ever responding to treatment. Hopefully we, your teacher, are living proof that this is not the case. Hopefully some of the case snippets and contributor wisdom that we've shared throughout the book have shown that this is not the case, that people with DID can respond to treatment. It may just take a little bit of creativity and application. So don't be disheartened if people with DID aren't responding to treatment as you learned it in your training manual. That may be where part of this myth comes in, because we know that this is not just with DID or dissociation. In many places in our field, if a person's not responding to the manual, then they're labeled treatment resistant. Are they treatment resistant, or are we not willing to adapt our strategies to their needs? The second myth is that people with clinically significant dissociation, especially those with DID, are more susceptible to putting people at risk. Now, this is one of those myths that has largely been promoted by media portrayals of DID, previously multiple personality disorders, as being violent, as having this alter or part who carries so much anger or rage, they can just come out on the screen and chew your head off without a moment's notice. If you look at data, and I'll show you a little later on this slide where you can get your hands on some of this good data, people with DID are no more susceptible than other mental illnesses, other mental health diagnoses to create harm, to be harmful to themselves or to others. And there's some criminal justice data that really does support this. So that is largely a myth if you think that people with DID are the worst in terms of violence potential. People with clinically significant dissociation, especially those with DID, cannot hope to live a fully functioning or thriving life. Once more, We hope we're some living proof as to why this is not the case. We hope that some of our contributors' wisdom we have shown for you is not the living case. And we want to give you just a little bit of commentary here. This is commentary based on Jamie's lived and clinical experience. This is nothing we have hard data to back up, right? We have seen some of the highest functioning, which can be a little of an ableist term, most successful people in a variety of professions have DID. Medical doctors, lawyers, teachers, engineers. Even as I say that, we want to be careful to not promote a message that you have to reach the top of your profession to show that you're valid, right, as a person or as a dissociative system. Just know that there's all different kinds of us out there, just like there are all different kinds of people with a variety of other mental health diagnoses. And what I find extremely interesting is sometimes the discussion comes up around, well, are people with dissociative diagnoses, should they be working as doctors, as clinicians? Could that put others at risk? The superwoman part that you saw in Petals of a Rose really prevents that from happening in most cases. There may be times like what I shared with my story, she gets a little tired out and we do have to take a leave from work, but typically us in a work setting is the least of your worries. It's the rest of life where some of these other parts may really be screaming at us. All right, DID is extremely rare. We saw the statistic at the end of Petals of a Rose that 1.5% approximately of the population has believed to have DID based on data that is available. And this number is similar to what you would find for bipolar disorder, schizophrenia. It is not as rare as people seem to think. And then finally, that integration of alters is the ideal goal for those with DID. I made a little commentary about this in the third module about how many psychiatrists, psychologists, professionals of various stripes who are operating from some older ideas around DID seem to believe that, well, in order for a person to live a fully functioning and thriving life, we have to bring these parts together in some kind of fused or integrated manner. And I want to be careful as I say that, because even two of our contributors from Dissociation Made Simple do now identify as integrated. So if that is a person's intention and choice and they believe that they can get there or their system can get there, that is wonderful. Remember, healing is very much defined by the individual or their system. Yet for so many folks with dissociative systems, there has been a lot of trauma around professionals telling them you have to integrate in order to be well. And we're very much now moving more in the direction of how can we create wholeness, cooperation. Even words you hear in other modalities like blending and fusion are not necessarily bad if the client likes those words. It's just keeping in mind that the forced integration of alters is not required and can really be activating for people who have been in and out of therapy. An article that we highly recommend, you can access it freely online just by searching the article, or we do have it available in your course portal, is a piece by Dr. Bethany Brand and her team, Separating Fact from Fiction, an empirical examination of 6 myths about dissociative identity disorder. This was published as a peer-reviewed academic lit review by the Harvard Review of Psychiatry, and we find this to be an excellent resource to pass along to doubters, especially psychiatrists that you may work with who say, DID, it's not real. Clearly, people who have that attitude may not be open to listening to a voice like mine and do want to see more hard numbers, show me data. This article really gives folks a lot of what you need. And this may also be good to share with clients who are doubting about whether or not DID or dissociation is a real thing. So this has always been an open access journal article, and let's please make use of it if it would be helpful. So moving on with a few other myths, misconceptions, horror stories, is this phrase, screen out. So clinical professionals asking at trainings, or in clinical group forums if they should screen out for dissociation in their clinical practices. And if you were trained in EMDR therapy or other types of more holistic trauma therapy, you may have been taught something like the Dissociative Experiences Scale or the DES. And I'll show you here at the end where you can get more information about the various scales and measures that are out there for assessing for dissociation. Really, all three of these first bullet points are interrelated. That a number that is often thrown out there, let's say on the Dissociative Experiences Scale, is a 30. That if a client has a 30 of 100 on the DES, there's a high probability for dissociation. So that rules out advanced forms of trauma therapy for them. Or for new clinicians, they may see a 30 as it's a screen out. Now, nothing magical happens at 30. First of all, the Dissociative Experiences Scale is just a screen. It's not meant to be diagnostic. And I think a lot of these numbers, kind of like my professor who said 200 cases, even though there's some clinical backing on what they mean, there's not any evidence that people with a 30 on the DES or 40 or 50 or higher can't handle trauma therapy and healing. And when we turn people away, and one of the reasons I see a lot of clinicians, even good clinicians, turn folks away with higher scores is this fear that I'm not going to be able to bring them back. There could be this fear that one of the parts is going to cause serious harm. There can be a fear that I don't really know what to do. So even though you have a right to refer out, especially if you feel you're operating outside of your scope of practice, please also consider the message that this sends to clients. I've talked to several personal friends who have been clients in the therapeutic systems over the years, and one shared something very poignant with me. A Marine veteran with a lot of traumatic stress issues, a lot of dissociation, and he had an experience with a therapist who touted herself as a trauma specialist. And she said something to him at the end of his first assessment like, you know, with the nature of your issues and the intensity of your dissociation, I don't feel that I'm able to work with you, and I want to find the best fit for you. So while he appreciated some of her candidness around, I don't want to do more harm, he still received that message as, I am too much to handle. I'm too much for you to deal with. And often clients implicitly receive that information when we tell them that their trauma is too much for us. So a little just bit of coaching that I'll give you here. Over the years, especially in my EMDR community, I've had a lot of people want to refer folks to me for working with DID because it just feels a little too out of my league. There's only so many of us out there who deeply, deeply specialize in this. And my greater challenge is, would you be willing to get the consultation so that you can work with your client yourself, especially if you have an established relationship? And a lot of what consultation does, and I know I've given a couple plugs for it already, and I'll give you more resources here on how to access it. A lot of what consultation is designed to do is to help you unpack some of your personal fears or trepidations. And a lot of those are there because of these myths. So something to consider here, and we'll continue building on this idea throughout the module. Clinical trainers. I've seen this happen in clinical training settings, and I've seen a lot of this happen with therapists who receive training from such trainers. Taking extreme measures to stop the first sign of dissociation that a training participant, that a fellow therapist, that a client might show during a practicum, or that a client may show in session. I've seen strategies like this used and demonstrated. Come back. Where are you? Clapping. Waving the hand in front of the face. Where'd you go right now? But in a very shaming way, as opposed to, Jamie, I'm wondering if you could tell me where you're at right now. probably the most extreme example of an extreme measure that I had shared by a Dissociation Made Simple contributor was a therapist who used a foghorn on her when he noticed her begin to dissociate in a group setting, and he encouraged her to use this foghorn technique on herself. And as she said, it just announced the shame. Versus, okay, you may dissociate at a light level, at a heavy level when we start to go into some more serious content. And to think of how more gentle strategies, especially in the vein of normalization, can be more appropriate. Where'd you go right now? Versus saying their name or the name of the part that may be out. Jamie, 9. I'm wondering if you could tell me where you're at right now. Did you go somewhere? And again, not assuming they went somewhere, but maybe asking. A gentle thing like, I'm wondering if we can go back to one of our grounding anchors. Can we take a breath together? Can we stand up and move around together? Do you need to take a little break outside? To consider how these gentler measures may work. And to also be aware that light signs of dissociation, just kind of maybe getting a little break of eye contact or drift, may not be impeding to the therapeutic process. We often like to share that we typically need a light degree of dissociation in order to do heavy work. It helps us. So this is more of the work I try to emphasize when I say dissociation is not a dirty word. Remember from an earlier module, right from module 1, it could be adaptive, it could be maladaptive, it can be both. So are you willing as a therapist or as a therapeutic trainer to not make assumptions? And this final area, we could probably do a whole course, a whole discussion around the ethics of this. It is something I just want to make sure is on your radar. And I go into this point cautiously because I am not advising that you go against the ethical codes as they're enforced in your state in terms of what your duties are as a mandated reporter, in terms of what your duties are, in terms of facilitating admission to an inpatient facility if that is clinically indicated due to suicidal intent, suicidal or homicidal plan that's articulated. All of that being said, I also want you to consider that the inpatient psychiatric facility is one of the least safe places for someone who dissociates, especially for someone who has a dissociative identity disorder. And one of the reasons this is because so many members of the medical model psychiatric system that tend to run these facilities still doubt about whether or not dissociative identity disorder is a real thing.